Thank you, Dr. Sharma, for the kind introduction. This is an interesting case that I was a part of recently. This is a story of Mrs. MR, an 88-year-old female with a 66-month history of worsening shortness of breath, fatigue, orthopnea, and decreased exercise tolerance to 1 block. She had past medical history of AV block and had bi-V pacemaker with his bundle pacing, history of coronary artery bypass grafting surgery with 2 grafts, and concomitant mitral valve repair, surgical left atrial appendage closure, and heart failure with reduced ejection fraction. Her medications included apixaban, amiodarone, torsemide, and atorvastatin, aldactone. So reasonable medications for heart failure management, and she was also monitored by the heart failure team. Then she was subsequently discussed with the heart team, and they found her to be at an extreme risk for tricuspid valve replacement surgically, and therefore she was referred for transcatheter intervention. TriClip was attempted, but that was unsuccessful because of poor image quality, large coaptation gap, and tethered leaflets due to RV dilation. And eventually she was referred for TTVR despite limitations of challenging imaging. Here are the invasive cardiac cath findings, non-obstructive disease in the RCA. She does have disease in the left coronary system, atretic lima, which I have not shown here, and the widely patent graft to the OM. And the right heart cath showed elevated filling pressures, PAPI of 2.5, moderate pulmonary pulmonary hypertension with a PASP of 45, and filling pressure ratios of 0.55. Baseline TTE showed dilated chambers, an RV forming the apex, very, very dilated RA, dilated and non-collapsing IVC, and concomitant mild aortic insufficiency and mild to moderate mitral regurgitation. She had massive tricuspid regurgitation, as you can see. Also had PISA of 0.72, regurgitation volume of over 50, and ERO of nearly 0.5. She had hepatic venous, her hepatic venous Doppler showed systolic reversal. All of these suggest of severity of the tricuspid regurgitation. So these are the baseline TEE images, which show that they were very, very poor mid-esophageal and deep esophageal windows, and therefore no help could be, they were of no help, not much help in deploying the devices here. Deep transgastric and transgastric imaging was more useful, and we can see that she had a couple of leads. She had his bundle pacing. This is why she had 2 leads in her RV, and sort of sandwich between the posterior and septal commissure at the top. And that's where the tricuspid regurgitation is originating. That's there the 2 leads are. She also had CT scan assessment as a part of her hospital policy. We do one in hospital, but also get help from the Edwards Life Sciences. So she was appropriately sized for a 44 millimeter evoke valve, which would have provided her a 4.3% annulus oversizing and a 13% basal RV oversizing. She had very good IVC to the TVA offset distances and also IVC to the TVA distance, making steering the guide catheters easier in her RV and RA. This is the intraprocedural TE and fluoroscopy to show how the stiff wires are positioned in the RV using steerable guide sheath, in this case the edgeless. And intraprocedural TEE, again, the deep transgastric views, and here we have used multiplanar imaging because the esophageal windows were not of much help. And you can see that on the top left, or on the left panel, that the guide was having a more posterior dive in the AP and having a more lateral dive in the SL leaflets. And this was corrected with the help of the windows in the transgastric using MPR imaging, and now we've got the guide more centralized in the annulus. And here we have exposed the capsule gap to assess the guide depth. This is quite an important step during the procedure because capsule gap actually correlates with where the anchors are going to be exposed, and these have to be below the leaflets and the annulus and above the paps. That's where the annulus, the capsule gap is, where you can see an echolucent area. And on here, you can see this is where the capsule gap is. So here, the anchors have been exposed to 90 degrees, and we have trapped both the leads into the posterior septal commissure. Again, the anchors are now flipped on themselves, and we have done intraprocedural ICE imaging as well to help with the correct positioning, because this is the point of no return, and this is quite essential or quintessential, because if any of the anchors, in fact, if one or two are not anchoring, it may be okay, but any more, and the valve can embolize. So here the TTVR is finally deployed, and we are looking at the eleocranial view, and we can see that both the leads are now safely jailed in the posterior septal commissure, and the patient did not develop any sort of new onset rhythm disturbances. This is the eyes, these are the ICE images also, again, using both sort of imaging modalities and showing a well-deployed valve, but you could also see that there is a bit of, the leaflets are jailed here on this side, and on the next slide, you can see that there is minimal PVL, and that's where the location of the two leads are. Post-procedural transthoracic echo showed only trivial tricuspid, valvular tricuspid regurgitation and reduction in the pulmonary artery systolic pressure, suggesting no pulmonary hypertension, and the systolic blunting of hepatic venous flow that improved from the beginning. Not much in terms of changes in the RV function. This is quite important, as these patients' RVs can be quite sensitive to the afterload mismatch. 1 month post TTVR, our patient feels much better and has improved energy levels and appetite. She has improved her exercise tolerance, has stable hemoglobin and renal functions. There are no new rhythm disturbances, and the pacing leads are not affected. The CT scan has also been performed 1 month post and did not show any halt. So this case actually highlights the challenges which can be encountered in certain patients during the complex structural interventions. In my case, or in this particular case, we did not have any mid or distal esophageal windows, and we had to use different imaging modalities. So it shows that these imaging modalities kind of complement each other and help perform these complex interventions. And also, the case highlights the fact that in today's day and age, when we have different sort of treatments available for the similar valve pathology, such as TriClip or the TTVR, how the decision-making tree has to be, how the algorithm has to be there to make the right choice for the right patient. And on that note, I will end. Thank you.
Great. Now, what is the anticoagulation strategy on this patient, antithrombotic?
So this patient is on apixaban post-procedure, and she was on apixaban pre-procedure as well, given her atrial fibrillation.
Let's say she wasn't in atrial fibrillation, and you put her on apixaban. How long would you keep her on it?
Yeah, that's one of the problems I think that we are going to encounter with these patients, especially the elderly patients who have high risk of bleeding, and we have to put them on an anticoagulant. I do get the point. But yeah, you're kind of caught between rock and hard in such situations, and in that situation, I guess, probably medical management if there is nothing much and if the bleeding risks are prohibitive.
One more question. As you know, jailed leads do fracture and dysfunction a significant amount of period of time. If this patient was patient dependent and did develop heart block, how would you manage that?
So this patient was pacing dependent. She had a complete heart block. I did mention that initially, and that's why. So anyhow, so if that is the case, then if that happens during the procedure, one has to be ready to pass the pacing wire immediately. And if that cannot be done, if that happens post-procedure, let's say 1 or 2 months or even 6 months, then in that situation, one can consider using a leadless pacemaker for these patients. Of course, then the problem is passing that large...
Or coronary sinus.
Or coronary sinus pacing. Absolutely, absolutely. But I think with the mitral surgeries and such, the coronary sinus anatomy in her was quite distorted. Thank you.
Just one question. What do you think was the mechanism of TR here? So you're saying that it was most likely pacemaker related?
So I think initially that was because of the mitral valve disease. And even though that has improved, which what I haven't told you guys is that now her mitral regurgitation has actually worsened. So she might be gearing up for a mitral clip at some stage. Yeah, so mitral clip, one of those things affecting, mitral regurgitation, affecting the right-sided tricuspid valve, and then the RV dilation. So it still was a, dilation and secondary tricuspid regurgitation. Yeah.
Okay, great. Now let's